In this video, we'll do an exam review of edema, but few important exam questions before we start the topic. Question number 1. What type of edema is produced by increased capillary pressure and capillary endothelial damage? Number 2. What type of fluid is present in the edema of mixed edema? Number 3. What's the role of hydrostatic and plasma oncotic pressure in the edema? Number 4. What's the role of ANP and BNP in edema? And number 5. In which edema there is peripheral arteriovenous fistula formation? Now edema. So what's edema? Edema is accumulation of extra fluid in the interstitial space or body cavity, so increasing the interstitial fluid volume. The extracellular fluid contains 1/3 of body water, which is about 14 liters, 2/3 of the body water being the intracellular, which is 28 liters. So the extracellular fluid, two portions are the vascular compartment and the interstitial compartment, in which there occur extra fluid accumulation. The interstitial compartment comprises of 75% of the extracellular fluid, which is about 10.5 liters, and the blood plasma that contains 25% of the extracellular fluid, which is about 3.5 liters. Now pathophysiology of edema. There is a lot of exchange between the vascular and interstitial compartment without fluid accumulation in the interstitial spaces. This static physiologic homeostatic environment is maintained by starling forces between these two compartments. Fluid goes out from the blood vessels at the arteriolar end of the capillaries into the interstitial space and goes back into the blood vessels at the venular end of the capillaries and by lymphatic without excess fluid accumulation in the interstitial space. Pre-capillary constriction lowers the filtration pressure, whereas post-capillary constriction raises. The starling forces in the vascular and interstitial compartment are: number 1, hydrostatic pressure and plasma oncotic pressure. The hydrostatic pressure pushes the fluid into the other compartment, whereas plasma oncotic pressure keeps the fluid in the same compartment. So the hydrostatic pressure pushes fluid in the blood vessel into the interstitial space, and the interstitial compartment pushes the fluid back into the blood vessel, whereas plasma oncotic pressure in the blood vessel keeps the fluid in the blood vessel, and the plasma osmotic pressure in the interstitial spaces tries to keep the fluid in the interstitial spaces. So the hydrostatic pressure in the vascular system and colloid oncotic pressure in the interstitial space, they cause movement of the water and solutes from the vascular to the interstitial compartment at the arteriolar end of the capillaries, whereas the hydrostatic pressure in the interstitial space and the plasma oncotic pressure in the vascular system causes the movement of the water and solute from interstitial space to the blood vessels at the venular end of the capillaries. And an imbalance between the hydrostatic and plasma oncotic pressure causes fluid accumulation or edema formation in the interstitial space. Causes of the edema are: number 1, decreased vascular plasma oncotic pressure; number 2, increased hydrostatic pressure; number 3, increased capillary pressure; or number 4, capillary endothelial damage; number 5, lymphatic obstruction; number 6, venous obstruction; and decreased arterial volume and decreased vascular resistance also cause edema. We'll discuss all these causes in a moment. The types of edema may be generalized or localized, pitting or non-pitting, and it may be transudate or an exudate. Generalized edema is pitting all over and leads to puffiness of the face with periorbital edema. In generalized edema, patient complains of difficulty in putting on shoes. Anasarca is also gross generalized edema. Now, organ structure malformation causing edema. Number 1, congestive cardiac failure. So what happens in congestive cardiac failure? In congestive cardiac failure, there is increased venous pressure and increased lymphatic flow or obstruction to drainage. That causes increased capillary pressure. So the cause of increased capillary pressure in CCF is increased venous pressure and increased lymphatic flow and obstruction. That causes edema. So what happens in impaired left ventricular function? There may occur peripheral edema or pulmonary edema. How does it occur? Let's discuss this. In systolic heart failure, there is incomplete ventricular emptying, and in diastolic heart failure, there is inadequate ventricular relaxation. In both type of systolic and diastolic heart failure, there is a pressure overload on the right ventricle. So the blood flows from the right atrium to right ventricle through the pulmonary artery to the lungs and goes back to the left atrium through the pulmonary vein to the left ventricle. This is the normal circulation of the blood. Since these are high pressure chambers, if there is an overload, the pressure goes back to the right ventricle and to the systemic venous pressure because the veins are low capacitance vessels. So increased right ventricular and systemic venous pressure leads to peripheral edema. And number 2, increased pulmonary arterial pressure in both these types of failure causes incomplete RV emptying, and back pressure causes pulmonary edema. So either pulmonary edema or peripheral edema because of increased venous pressure. Now the role of ANP and BMP. In congestive cardiac failure, distended atria and ventricle of the heart produce atrial natriuretic peptide and brain natriuretic peptide respectively. BNP is also produced in the brain. So what do they do? ANP and BMP are natural diuretics. They decrease the sodium and water reabsorption in the proximal tubule that leads to diuresis, preventing edema formation. They also decrease renin, angiotensin and aldosterone production. And number 3, ANP and BNP, the natriuretic peptides, are vasodilators. So they dilate vein, decrease the central venous pressure and decrease cardiac output. And number 2, they dilate arteries that decrease the systemic arterial blood pressure. So in cases of CCF, ANP and BNP prevents edema formation. Natural diuretics, normal and abnormal natriuretic peptide levels. A normal natriuretic peptide level is 100 pg per ml, and a level of more than 100 pg per ml is suggestive of congestive cardiac failure, and a level of more than 450 pg per ml is strongly suggestive of the congestive heart failure, and a level of more than 600 pg per ml is the average natriuretic peptide level in CHF, congestive heart failure. Now the second condition that may cause generalized edema is nephrotic syndrome, and this occurs in glomerulonephritis and diabetic glomerulosclerosis and hypersensitivity reactions. In nephrotic syndrome, there is heavy protein loss of more than 3.5 grams per day, along with hyperlipidemia and edema. So there leads to hypoalbuminemia and generalized edema and Anasarca. Condition number 3 that causes edema is acute glomerulonephritis. There occur proteinuria, hypertension and hematuria in acute glomerulonephritis that causes edema. There is salt and water retention with normal to increased cardiac output. The condition is very similar to cardiac output, but to the congestive cardiac failure, the salt and water retention with normal to increased cardiac output. Number 2, normal arteriovenous oxygen difference. And the third difference with the congestive cardiac failure is pulmonary congestion with normal heart size. Heart size increases in congestive cardiac failure. Condition number 4 that causes edema is cirrhosis. There occur jaundice, spider angiomas, abnormal LFT, ascites, and edema of the lower limb initially. On examination of cirrhosis, the liver is shrunken due to fibrosis, not enlarged, and there occurs hypoproteinemia in cirrhosis because liver fails to produce proteins including albumin. The blockade of hepatic venous blood flow leads to venous congestion and obstruction to lymphatics with portal hypertension. And there occurs salt and water retention in cirrhosis. Why? Due to decreased metabolism of aldosterone. Aldosterone produced by adrenal cortex and metabolized by the liver. In liver failure, it's not metabolized, so its toxicity increases and causes edema formation and hypertension. Number 5, edema of malnutrition. There occur hypoproteinemia, caloric deficiency, and hypokalemia. So there is protein calorie malnutrition in edema of malnutrition. There occur peripheral AV fistula formation. So that AV fistula formation leads to decreased systemic perfusion and arterial pressure that increases the edema formation. So peripheral AV fistula formation occur in malnutrition. What's refeeding edema in malnutrition? In malnutrition, increased diet increases insulin production, and that causes an increase in sodium reabsorption from the renal tubule that causes increase in edema. So refeeding in malnutrition increases insulin production that causes increased sodium reabsorption in the renal tubule. Now transudate and exudate. Increased capillary pressure as occur in CCF or decreased oncotic pressure as occur in malnutrition or nephrotic syndrome. Edema is called transudate because it's poor in protein, whereas in exudate, capillary endothelial damage causes edema which is rich in protein, that is known as exudate, or if there are cells, it's also exudate. Examples are edema in boiled and carbuncles because of the infection. Now localized edema. Localized edema may be non-pitting or mixed pitting or non-pitting depending on the situation. Now localized non-pitting edema. The non-pitting edema is seen especially in number 1, lymphatic disorders, number 2, thyroid conditions, number 3, capillary endothelial damage, and number 4, edema of inflammation. Now number 1, lymphatic disorders causing non-pitting edema. The lymphatic circulation blockade causes lymphedema that occurs, for example, after mastectomy, lymph node surgery, radiation therapy, or it may be congenital. So after mastectomy, it may be due to block of the lymphatic vessel. Number 2, hyper or hypothyroidism sometimes causes edema which is non-pitting. Vertebral mixed edema in hypothyroidism is characterized by non-pitting edema. And why? Due to increased glucose aminoglycan. Number 3, capillary endothelial damage causes increased protein transfer from the blood vessels into the interstitial space, causing edema. So capillary endothelial damage causing protein transfer to the interstitial space. Examples are infections, for example bacterial, viral infections, or hypersensitivity reactions and toxin. Other conditions like burns and allergic reaction and trauma may also cause. Blisters and bullae in the burns form non-pitting edema are the examples. Now localized mixed edema may be pitting or non-pitting. Number 1, decreased arterial volume and decreased vascular resistance, vasodilatation, causes localized edema. Why? Due to sodium retention. Number 2, edema limited to a limb is usually due to lymphatic or venous obstruction. Number 3, thrombophlebitis of one limb can also cause localized edema of the limb due to increased in venous pressure. Number 4, edema in hemiplegia is usually unilateral and is due to decreased lymphatic or venous drainage. Number 4, jugular vein obstruction may cause increased venous pressure that causes edema of the face, neck, and upper limb. So jugular vein obstruction causes edema face, neck, and upper limb. Edema of heart failure is associated with increased jugular venous pressure. Number 7, chylous effusion. What's that? It contains chylomicron with triglycerides and lymphocyte. Number 8, ascites and pleural effusion are also examples of localized edema. Number 9, cerebral edema is extracellular fluid accumulation in the brain and occurs in trauma, tumors, infections, stroke, or reduced oxygen at high altitude. So what are the features of cerebral edema? It causes drowsiness or loss of consciousness leading to brain herniation and death. So cerebral edema If the pressure increases, it may cause brain herniation and death. Prolonged standing causes edema in the lower leg. Now, other conditions that cause edema. Number 1, angioedema is focal edema of the dermis and subcutaneous tissue. Why does it occur? Number 1, it is caused by mast cell derived mediator. And what are that mediators? Histamine and bradykinin. And number 2, complement derived mediators also cause angioedema. Angioedema is caused by allergy to drug, venom, food, pollen, or animal dander. So pollen and animal dander cause angioedema due to the release of histamine and bradykinin. Now sepsis. The edema caused in sepsis that occur in sepsis, there is fever, tachycardia, focal infection, and it's a painless edema. Whereas the edema of cellulitis is red and painful, tender and circumscribed edema that occur with necrotizing infection and constitutional symptoms. So the edema of sepsis is painless with fever and tachycardia, whereas edema of cellulitis is painful with circumscribed edema that occurs in necrotizing infections. Number 4, filariasis. It causes edema, lymphatic parasitic focal edema in endemic area. Acute symptoms include fever, lymphadenitis, lymphangitis, and epididymitis. So in filariasis there occur lymphadenitis, lymphangitis, and epididymitis. And elephantiasis is a massive swelling in the legs or scrotum in filariasis due to lymphatic obstruction. The edema in trichinosis. There is periorbital edema with fever, muscle pain, and eosinophilia. So periorbital edema with fever, muscle pain, and eosinophilia. Diagnosis with enzyme immunoassay and muscle biopsy. Treatment of trichinosis is mebendazole or albendazole, and in severe cases prednisone. Now lymphedema. Lymphedema is collection of lymphatic fluid in interstitial tissues. Number 1, obstructive lymphedema. It occurs following radical mastectomy, and edema of the arm after mastectomy is due to removal of the axillary lymph node. Number 2, Turner syndrome. Lymphedema of hands and feet in the newborn. In Turner syndrome occur due to defective lymphatics. Number 3, cystic hygroma. In cystic hygroma, dilated lymphatic channels in the neck produce webbed neck. So webbed neck in cystic hygroma, and edema hands and feet in Turner syndrome, and edema of the arm following radical mastectomy. And number 4, damage to the thoracic duct occur after malignant lymphoma or trauma that causes lymphedema. Now answers to the questions. Question number 1, what type of edema is produced by increased capillary pressure and capillary endothelial damage? Capillary endothelial damage causes increased protein leakage into the interstitial spaces causing edema, whereas in increased capillary pressure, there is increased venous pressure, increased lymphatic flow and obstruction to drainage, and that causes increased capillary pressure. So increased venous pressure and lymphatic obstruction causing increased capillary pressure leading to edema as occur in CCF. Number 2, what type of fluid is present in edema of myxedema? In hypothyroidism, characteristically, there is pretibial myxedema due to increased glycosaminoglycan. Question number 3, what's the role of hydrostatic pressure and plasma oncotic pressure in the edema formation and prevention? We already discussed it earlier briefly here. The hydrostatic pressure pushes the fluid in the other compartment, and the oncotic pressure keeps the fluid in the same compartment. So the hydrostatic pressure pushes the fluid in the blood vessel into the interstitial space, and in the interstitial compartment pushes it into the blood vessel, and the plasma oncotic pressure in the blood vessel keeps the fluid in the blood vessel, and that in the interstitial space keeps it in the interstitial space, and an imbalance between the two causes edema formation. Question number 4, what's the role of ANP and BNP in edema? In CCF, distended atria and ventricle of the heart produce ANP and BNP respectively. ANP and BNP are natural diuretics, and they decrease sodium and water reabsorption in the proximal tubule. Number 2, they decrease renin, angiotensin, aldosterone production, and number 3, they are arterial and venodilators. So venous Vasodilatation causes decreased CVP and decreased cardiac output, and arterial dilatation causes decreased systemic arterial pressure. Question number 5. In which edema there is peripheral arteriovenous fistula formation? In edema of malnutrition, there is peripheral AV fistula formation that decreases the systemic perfusion and arterial pressure, leading to increased edema formation. Pre-capillary constriction lowers the filtration pressure, whereas post-capillary constriction raises it. Prolonged standing causes edema in the lower leg, and elephantiasis is a massive swelling in the legs or scrotum in filariasis due to lymphatic obstruction.